recorded. You'll see the red circle up there. When it comes time for questions, there's a chat button at the bottom of the screen. You are free during Sarah's talk to type your question into the chat if you want. You can do that anonymously, or you can do it with identifying yourself. If your question is too long and you would rather us call on you after her talk, then you can put a note in the chat to say, call on me, and that way the order of the questions will be respected. If we just wait to the end when everybody raises their hand, I'll be moderating. I actually can't tell who raised their hand first. So if you want to get in the queue to ask a question, feel free to enter it anonymously or by putting your name and a note to call on me and for me to call on you in the chat as she goes along. Are there any questions while we go? Because now's the time to quickly ask, otherwise you're all going to be muted for her presentation. All right, I think I just see thumbs up. Yay, Sarah, from your friends who've graduated. Okay, well then without further ado, I'm gonna mute myself and we will let Sarah take over and tell us about what she's been working on for her dissertation. Take it away, Sarah.
Awesome, thanks. All right, so today I'll be talking about forecasting mental distress using healthcare claims data. And I'm very grateful for all of my committee members who are here today, virtually, not physically, but I'm grateful for your support today as well as in the past year. All right, so let's get going here. First, let's define mental distress. Mental distress is the condition of extreme anxiety or sorrow at a level that significantly impacts daily living. Of course, we all have days when we're sad or fearful, and these emotions aren't inherently bad. In fact, we need them to live a rich, full life. Being sad helps you cope with loss and may improve memory and judgments. And acute fear is like a superpower. It increases your heart rate to prepare for physical activity, among other things. But when negative emotions are prolonged and interfere with our daily activities of normal living, they become mental distress and may require some intervention before they are resolved. And unfortunately, mental distress isn't abnormal. Depression and anxiety, two of the most common mental illnesses, have reached record highs in the US in recent years. For example, 7% of adults have had at least one major depressive episode in 2015. And according to a recent review, anxiety disorders affect up to 25% of the population. And experts also expect a tidal wave of mental distress problems with the COVID-19 pandemic and all the accompanying societal changes. This results in an estimated $100 billion lost annually due to absenteeism, and more importantly, on average, there's one death by suicide every 12 minutes in the US. All this mental distress certainly paints a bleak picture. So what can we do to prevent these outcomes? First, let's do a quick metaphor on prevention from our public health colleagues. Suppose you're hiking by a beautiful raging river. When suddenly you spot someone struggling to stay above water. Quickly, you call the authorities, and they pull out the victim and administer CPR. The individual has been saved. Hurrah. But they will have to live with this physical and psychological effects of near death for quite some time. Soon you spot another victim struggling to stay afloat, and again call the rescue team, and they save the victim. But where are all these people coming from, you wonder? So you set off upstream to see if you can find any clues. A little further upstream, the river is more calm, but moving quickly. You notice some people floating down the river, waiting for the right time to get out. You holler at them that the river gets much more rough downstream, and maybe you toss out a life preserver to help them out. It's a bit of a struggle, but they're able to get out. And again, you continue upstream to see where you can find where all these people are getting in. Finally, you spot them, a large crowd of people on a cliff edge attempting to take the best selfies for their Instagram stories. The river is pretty calm here, and the people that accidentally fall in don't know the danger that awaits them downstream. So you build a fence and install a warning sign to prevent people from falling in the first place. This is a small bother to those Instagrammers, but you know it will save some of them from falling in. All of these preventative elements are important for rescuing people who are drowning, but they come at different costs to both the rescuer and the individuals at risk. Today's tools and care pathways for mental health are like the helicopter rescue. They focus on finding cases of those who are already drowning in mental distress and do their very best to mitigate the related symptoms. But it's crucial that we move upstream to find ways that proactively identify individuals at risk of having severe mental distress. Doing so would allow us to target ongoing treatments closer to the source of the problem and to those become more severe cases. Today, we're going to talk about our progress towards making the goal of identifying these individuals in a clinical setting. Specifically, about how we can identify these individuals in distress using standardized surveys and medical claims data. Then we'll take a step back, discuss resilience and our work in modeling it as a latent state. And finally, we'll talk about how we can combine this to improve mental distress forecasting and identify those at increased risk of becoming distressed. But first, how exactly can we identify these people? Traditionally, we use things like standardized surveys, like the Patient Health Questionnaire 9 or PHQ-9, and the PHQ-2, which screen for major depressive disorder, and the GAD-7, which screens for general anxiety disorder. Despite recommendations from the US Preventative Task Force to screen all adults for depression, few individuals have one of these surveys recorded in their medical record. In order to achieve generalizable results, we need more data on whether people are distressed than is available in these standardized surveys. So we turn to medical claims, which have the important benefit of being much more prevalent. But there are some important things we need to keep in mind about this data. First, let's understand what's in a medical claim. Here is a very simple overview of how the healthcare system works in the US. In the US, when an individual becomes sick, they can visit a provider to tell them about their symptoms. The provider might order some tests or conduct various procedures as a general consultation or a surgery or a lab test. The provider then submits a medical claim to the patient's payer or health insurance company in order to get paid for the service they provide. And the payer pays back for that particular service. It's a bit of a negotiation, and the provider has an incentive to make sure that they're using the right codes and justification to make sure that they get paid for the services that they did provide. Specifically, a medical claim includes data about the medical visit, primarily for payment purposes. Data included in these claims include a patient identifier, the date of service, the procedural code, and several diagnosis codes. Importantly, these diagnosis codes are used as justification for the procedure that was performed. They don't necessarily communicate a patient's health. I want you to think of these diagnosis codes more as justification codes. For example, you might show up to a doctor's office with joint pain and fatigue, and the doctor might suspect you have rheumatoid arthritis. So she would likely order a blood test or imaging test to check this hypothesis. The provider would then submit a claim for conducting these tests and list rheumatoid arthritis as the diagnosis code as a justification, even though the results from those tests might come back negative. So we need to be careful with how we interpret these codes. And these codes can get quite detailed. For example, here are some codes that are for rheumatoid arthritis on the top and major depressive disorder on the bottom. The first three characters represent a general category of the disease. So for example, M05 is for rheumatoid arthritis, F33 is for recurrent major depression. And each additional character in that code adds detail about the condition. You can see it gets quite detailed with M05.621 is for RA of the right elbow with involvement of other organs and systems. Separately, pharmacy claims are submitted when a patient fills a prescription. These claims are genetic. They include things like the genetic drug name and the number of days of medication that was given to the patient, along with things like the date of prescription and the patient identifier. With pharmacy claims, there's a bit of a complication due to pharmacy benefits managers or PBMs who manage the prescription benefits. Will negotiate between health insurance companies, drug manufacturers, pharmacies. And as a result, the insurance company might not have all of the data on the prescriptions that you have filled. This important tidbit of information will be important later. Now, despite all of these caveats of the health insurance claims, we can use them in connection with a standardized surveys to have a much more dense data set of distress labels. Specifically, we want to learn a model to identify distress in the medical claims data from the paired standardized survey data that we do have. That way we can apply this model to all medical claims data that don't have that matched standardized survey data. For this project, our data comes from a group of de-identified matched claims and EHR data. We use 3 years of retrospective data. All individuals in the data are adults. They have at least one value. They have at least 5 medical claim records during the study period. Of course, this limits our finding to individuals who are that do have insurance and that are using the healthcare system on average of more than once per year. This results in 3,400 surveys from just over 2,400 individuals. 2/3 of our population is female, and the median age at the start of the study was 65. We use this available PHQ-9, PHQ-2, and GAD-7 surveys, and the cutoff scores shown here in the bottom. These scores are the same that are generally accepted for finding cases of distress in a clinic. If an individual has more than one survey on the same day and any survey indicates distress, we will consider that day to have the distress label. For example, if in my medical record I have both a PHQ-9 and a GAD-7 with a score of 3 and 10 respectively, it would be labeled as distressed on that day, despite the PHQ-9 with a score of 3 labeling me as not distressed. We also draw 40 input features from the medical and pharmacy data to build this model. They're from 4 general categories: depression, anxiety, sleep disorders, and chronic pain, because these diseases are highly comorbid and tightly linked to mental distress. But future work should explore many other possible indicators of distress in the claims data. In particular, we're looking at the number of claims with one of the following ICD-10 codes used in either the primary, secondary, or tertiary diagnosis code. We also count the number of prescriptions in each of the 9 categories shown here. These roughly map to the same 4 disease categories, and there's some overlap between them. But since prescriptions are given for off-label reasons often and at different days' supply, we actually make 4 features for each prescription category by counting the number of prescriptions that have at least 1 day, at least 7 days, and 14 days, or 28 days of supply. This gives us 36, that's 4 times 9, prescription features for a total of 40 features shown here. All right, so we choose to compare 3 different windows for counting these features, specifically happening on the same day as the survey, happening up to 7 days later, happening up to 14 days later. This is important because some visit the doctor on Monday and get a prescription for an antidepressant that they don't fill until Wednesday. If we require that all events happen on the same day, we would completely miss this event. And finally, we choose to use 2 main model types: a simple definition-based heuristic and decision tree models. Our simple definition is based on our hypothesis that an individual that has any of the diagnosis codes or any of the prescriptions from the previous slide I listed, that individual is distressed. The decision tree models, on the other hand, are learned or trained using the input claims data compared with the output survey labels. We choose decision tree models because they're known for their relatively simple and interpretable structure. All right, so in order to train these decision tree models, we split the data into training and test sets so that the 2,400 surveys are in the training set and just over 1,000 are in the test set. We use 5-fold cross-validation to select the best parameters for the decision tree. But of course, there are many possible ways of deciding what is best. Many times we use accuracy, which ranges from 0 to 1 and is computed as the number the model got right over the total number of samples, with the higher scores getting a significantly higher score signifying a better model. However, accuracy is not a great metric to use when the classes are imbalanced. Thankfully, more people have surveys that indicate they're not distressed than indicate that they are distressed. So we need a different metric here. We choose to use Matthew's correlation coefficient. This is a metric that isn't prone to the same problems of class imbalance. It ranges from -1 to 1, with higher scores being better. You can see that the equation is a bit more complicated and that it evenly uses all 4 parts of the confusion matrix: the true positives, true negatives, false positives, and false negatives. Scores of 0, which we'll see soon, indicate that the model is only outputting a single label. Without further ado, let's get on to the results. So here I'm only showing the best models, features computed at 7-day window, as these were the best models overall. The decision models, we find that a model that was allowed to perform the best on cross-validation. We also find that the simple diagnosis definition performed the best of all the simple definition models. Remember that the rules for these models were set before looking at any of the data, so there's no need to do cross-validation because we aren't training anything here. You might also notice that the models with only prescription features actually do quite poorly, pretty close to 0 on the MCC scores. This is due to the fact that many of these individuals in this particular data set didn't have prescription data in our data set, likely as a result due to pharmacy benefit managers holding that data. When we look at the holdout test data, however, we can see that these models performed well with MCCs of around 0.29 and accuracies of about 75%. We can take a peek under the hood here, though, and see how these models are making their predictions. The simple definition isn't actually a tree model, but I'll use it here just to get you oriented to how to read as a decision tree. In order to read it, you start at the top node there and evaluate this expression. If the expression is true, you move to the left. If it's false, you move to the right. You keep going until you're at the end or the leaf of the tree. The class or label of that leaf is the label you give the sample. We color coded the boxes so that they correspond with the label. Blue is for doing well or not distressed, and orange is for distressed. The darker the color, the more sure we are of this label. Let's do 2 quick examples. First, let's have no diagnosis codes in any of the 4 categories. So starting at the top, the first box is true because there are 0 depression diagnosis, which is less than 1. We move to the left and so on, all the way down the tree until we are at the last nodes. Therefore, we label this sample as not distressed. If instead we have 2 diagnosis codes for anxiety during the time window, but no other codes, we would again start at the top, move to the left because we have no depression codes, and then move to the right because we have 2 anxiety codes. This person would be labeled as distressed. All right, so now if we look at this decision tree model that was learned from the data, we have a slightly more complicated tree. A couple of quick things to point out. First, we only use 1 prescription feature in this tree, and it's right there at the top. If a sample has, if an individual has 14 days or longer supply of a drug in the other depression category, they're labeled as distressed right away. Second, you might notice that the side of this tree is really similar to the simple definition version. The main difference here is that in this data-driven model, an individual can have up to 1 pain diagnosis, as you can see here, without being considered distressed. There are 4 boxes on the right part of this tree, however, that are labeled as not distressed. You can see them here in blue. And some of these patterns don't really make a lot of sense. For example, you can see that if you have 20 diagnosis codes within 7 days for anxiety, we would label that person as not distressed according to this tree. That doesn't make any sense, and so we looked into this more and found that these 4 blue boxes on the right side of the tree contain only 10 samples of the 2,400 in the training set. So we chalk this up to artifacts and suggest that future work continue to refine this model. With all that being said, we can look at the differences in these 2 different labels, the tree model and the definition model, to see the similarity. The plot on the left will show the differences in the labels for 100 different individuals for 2 years, 1 row per person. Each of the labels are colored. Labels that are in the off-white color mean that the label was the same. Red means there's a difference in labels with the tree model giving a label of distressed, but the definition label giving a label of not distressed. The blue means the opposite. We find that there's a difference in less than 3% of the days. So as a result, we use the data-driven model for the rest of this talk. And to wrap up this section, we needed to find a way to expand our data set of distress labels from standardized surveys. And we did so by training models that converted claims data into distress labels. We were able to create a data-driven definition of distress that achieved a Matthews correlation coefficient of 0.29 and had an accuracy of about 75% on a holdout test set. Next, we move on to modeling resilience as a latent state. But let's take a step back and ask ourselves, how does someone become distressed? What might be an early warning sign? And we'll look at another metaphor, and that of forest fires. These devastating events sometimes seem to happen for no reason at all. But when we look closely for patterns, we notice two things. First, there's a catalyst that starts the fire. These can be big events like lightning strike or a big storm that blows down a tree into a power line. Or they can be seemingly smaller events like a campfire that gets out of control or a cigarette butt flung out of a window. But importantly, a forest fire also needs the right conditions to be able to spread that fire. Things like the moisture of the vegetation needs to be low, the wind needs to be strong, or there needs to be a lot of underbrush that hasn't been, that's dry. These conditions are necessary but not sufficient to spreading a forest fire. In other words, these conditions increase the risk of a forest fire but need to wait for a catalyst for that to actually happen. If these conditions can be easily tracked, then a targeted early warning system about the most risky areas can be available. In a similar way, mental distress has many possible catalysts: losing a job, the death of a loved one or spouse, getting a diagnosis like cancer. Other major life transitions like having a baby or graduating can even be catalysts. And even things that seem small, like having an argument with a friend, can be the catalyst for extreme sorrow and anxiety if the underlying conditions are right or wrong, depending on how you look at it. In our work, we're interested in predicting the conditions that make any catalyst more likely to cause mental distress. This leads us to the study of resilience, or the capacity and dynamic process of adaptively overcoming stress and adversity while maintaining normal psychological and physical functioning, like a tree being able to bend in the wind without breaking. Resilience is often measured using surveys and other self-reported mechanisms, and unfortunately, like mental distress surveys, we just don't have a lot of dense data on this topic for many people. It also leads us to think about allostatic load, or the wear and tear on the body from repeated exposure to stress. Picture a rubber band that you've been stretching over and over. Eventually it'll wear out, and even the slightest stretch will cause it to break. Allostatic load is usually measured using many different indicators associated with the neuroendocrine, cardiovascular, immune, and metabolic systems. Specifically, we usually use lab tests to get these indicators. But again, not everyone has these lab tests, and certainly not at the dense timescale that we'd like. So again, we need to figure out a way to estimate resilience or allostatic load without directly having access to this information. Specifically, we decided to use a mathematical model called a state space point process to model a proxy of allostatic load using the rate of encounters with the healthcare system. Our hypothesis is that the higher the rate of encounters one has with the healthcare system, the less resilient they are, or the higher the allostatic load they have. To make this a bit more concrete, we'll take all the encounters someone had with the healthcare system and smash it into a binary sequence of events. You get one number for each day. A 1 means that you interacted with the healthcare system, and a 0 means that you didn't. In this model, we don't differentiate between the different kinds of visits. So you might have visited somebody for a cardiac problem, and then something that was respiratory, and then something that was for the GI. We smash all of this information into a single binary vector. Let's get to the math of how we actually do this. First, we're trying to estimate the rate of events. This is that lambda on the far left side of your screen, and it's individualized for each person, and it changes each day, which is given by t. We then have a resilience component here in blue, and a history component here in purple. And down here on the bottom left, we'll keep a running list of the variables we need to estimate. First, we set R as a hyperparameter. Right here at the top of this summation. This is the number of step functions and determines the length of a resilience window. Next, we have theta, which will be our latent resilient state. It's specific for each individual K, and there's one for each time bin. this is another parameter that we need to estimate. We also have a set of step functions, G, that serve to select one of these theta values at a time. These are formed in connection with capital R, so there's nothing new to estimate. All right, now we look at the history component, and first we see that we need to set J as a hyperparameter, which is the number of history effects we look into the past for. And we also look at the it's the maximum number of days that we consider that have an effect on the current rate of events. Next, we have the actual history effects, gamma. Note that these are just indexed by J. So this is assumed to be the same for all people in our population. We can think of this component as the general estimate of the general cadence in healthcare visits. Finally, we have N, which is a binary indicator of a healthcare event. We note that this is indexed for the individual and for a specific time. So even though the history effect is the same for the whole population, this component is still individualized because we're considering a specific person's history. In this next step, we've added two more things to estimate, J and gamma, and the observed data is given to us. We also need a state update equation. We just use a simple random walk in this model with mean 0 and covariance sigma. This adds one last parameter to estimate. And as we mentioned before, the observations are given as a binary vector of events, one for each person. We can estimate all of these parameters using the expectation maximization algorithm. We want to compare this somewhat complicated model to slimmed down versions. The model we just talked about is down here on the bottom, and the state space model, it is the state space model with history. We can take away the history component and just estimate the resilience effects, assuming that the history doesn't have any effect on the we can also make the resilience component static by having a single resilience factor for each individual. This is the static model with history. And finally, we can take away the history component from the static model. All right, let's get back to some actual data. So we used the data set very similar to the identification of the model. We had a 3-year study period, required that individuals in our cohort were adults and had at least one valid PHQ-9. We had insurance coverage and at least 5 medical claims. This gave us 322 individuals. We split them into train, validation, and test groups. We had 121 individuals in the training set, and these people were used to select the best R, J, and gamma values. We set aside the validation and test groups, and we'll talk about those again later on in the presentation. All right, so here we're going to plot all of the individuals in the training set on the y-axis, ordered from the least number of events on the bottom to the most number of events on the top. The x-axis shows time, and if we plot a vertical black line for each event, we get something that looks like this. We can see that there are some individuals that are visiting the doctor quite often up here at the top. And there are others that have periods of high engagement, like this part here in the middle and these parts over here on the left, before settling back down into a lower rate of events. We use the first 3 months in order to estimate the history components, and we use the last 3 months as test data to see how well these models generalize. So the training is able to use the middle 30 months of data. We use 3 different evaluation metrics to find the best models here. First, we use the Aka-Ike information criterion, which is used to select the best model within each of the 4 class models. This metric trades off between goodness of fit and the simplicity of the model. We also use the Kolmogorov-Smirnov test statistic to determine how well the rescaled times approximate a uniform decision. And we use the number of significant autocorrelation function parameters as a measure of the independence of the rescaled times. We note that lower is better for all 3 of these metrics. And now for some results. Here we have listed the 4 different model classes, and using AIC, we found the best R, or the length of that resilience window, and the best J, or the best number of days of historical data that we should be using. We don't need R for the static models, but we found for the state space models that 15 days and 30-day windows were the best. And again, for the models without history, we don't need a J value, but for the static models with history, we found we needed a full 85 days to get a good approximation of the rate of events. But for the state space model, we only need the past 16 days because the changes in rate can be approximated by the changing resilience state. Next, we select the best two models using the testing statistics out there on the far right of the table. We select, first we select a model with the best test KS statistic, which is the static model with history. And we also select the best, we select the state model with history for having the lowest number of significant ACF parameters on the test data. Let's take a look at these two models and see what they do to estimate history and resilience effects. In this plot, we're going to be looking at the history effects. The top of this plot, anything above the line, will indicate that an event at that time, back in history on the x-axis, increases the rate of time, increases the rate at the current time, and anything below the line indicates that an event at that past time decreases the rate at the current time. All right, so you can see here that it starts off as a cyclical pattern, and we can see that, for example, if you visited the doctor 1 to 5 days ago, you have an increased probability that you'll visit the doctor today. Whereas if you had an event 16 to 20 days ago, you're less likely to see the doctor today. This makes intuitive sense because it's quite common for the doctor to request that you book a 1-week follow-up or a month follow-up, but very rarely does the doctor request that you return within 17 days of today. We can see a similar pattern in the history effects from the state-based model. However, we notice that we need a much shorter history to have a good approximation of the current rate of distress. Next, we look at the resilience component. This is the static model, and we see that the rate of events roughly increases as the subject number increases. Remember, this is because we ordered the subjects from the least number of events to the most number of events. There's some notable differences, like this person here at the end, that is quite lower than we might expect. But if we look back at the plot of all events for this individual, we can see that many of the events are happening in the first 3 months or the last 3 months. Remember that these 6 months, 3 on either side, weren't used in estimating the resilience component. This highlights a downfall of the static model. It can't handle these periods of high interaction before returning to baseline. But let's take a look at how the state-based models do. Here, because each individual has their own resilience component as a function of time, we have one small box plot, one small box for each person. We're looking at just a small handful of all the people here, but you'll get the general idea. Each box represents a person. The x-axis is time, and the y-axis is the rate of events per 30 days. If we look at the first two plots, we can see that they're quite different from each other, despite being used within the same modeling frame. Person 28 has a low rate of events the whole time, but person 29 has a high period of interaction with the healthcare system near month 30 before returning to a baseline level. And if we look at some other individuals, we can see these patterns can be quite diverse between one another. In summary, in trying to estimate the rate of healthcare events in order to get a proxy of allostatic load, we found that a cyclic rate of returning to the healthcare system. We also found a variety of patterns were present in the latent resilient effect. And now that we have these in two important building blocks, a model to generate labels and a model to estimate resilience, we can move on to what you've all been waiting for, forecasting mental distress. Specifically, we'll start with forecasting month in advance. We want to include common features that others have shown to be associated with mental distress. So for example, we'll use gender. Women have been shown to have higher rates of distress. Age is also often included, but with mixed results on how that interacts with distress. Some research suggests that it increases, others suggest it decreases, and still others say it's more of a U-shaped interaction. Finally, lower socioeconomic status, or SES, has been associated with higher distress. We use two proxies of this in our model, namely the average household income of the geographic area of the individual, and secondly, the percentage of individuals in that geographic area that have a college education. All right, we also want to test the impact of including the current distress label and the rate features on the performance. We have two specific hypotheses here. First, including an individual's current distress state will improve future forecasts of distress. And second, using the rate of healthcare events estimated from the state-based model will be better than those made using estimates from the static model. In order to test these hypotheses, we split our features into 6 categories. Each model includes basic features, as listed here. We also then have models that are using just the static rate features or just the state space rate features. We compare adding the current distress state to each of these feature sets to make 6 total sets of features. We then compare the feature set without the current distress state to the corresponding feature set with the current distress state. We also compare the static rate to the state space rate, both with and without the current distress feature. All of these feature sets will be compared using paired t-tests. The data we use for this portion is the exact same as the data that we used in the previous section, but this time we use all 3 partitions of the training set, the train, validation, and test sets. We also randomly sampled the test set 5 times to create 5 sets of data that we can use to compute means and variances of what we would expect generalization performance to be. We again use the MCC to select the best models for each feature set. We also choose to set up the problem 3 different ways. First, we have the very basic 2-class model where each 30-day period is labeled as either well or distressed using the tree-based models we talked about in the first part of this talk. Next, we use the output of that, the 2-class model to create a 3-class labels of directional change. Specifically, if there's no change from 1 month to the next, we label that as 0. If there is a change for the better, we give that a label of -1, and a change for the worse gets a label of 1. Finally, we enumerate all 4 possible states here to get 4-class labels. Specifically, staying well gets a 0, staying distressed gets a label of 1, getting better gets a label of 2, and getting worse a label of 3. All right, so now we're ready to find the best models here and compare them to one another. We're going to look at the MCC of the 1-month forecasts for each of these 6 feature sets and each of the 3 setups. I'll draw your attention to the fact that the feature sets are actually paired in color with their current distress state counterparts. The baseline MCC is 0 for all 3 model setups. The height of each bar on this plot represents the average, and the error bars represent the standard deviation on those test sets. Visually, we can see that adding the current distress label improves each of the feature sets. We can also see that the state space features seem to have only improved in the 4-class models. But looks can be deceiving, of course, so we need to check these observations with paired t-tests as described before. Statistics can also be deceiving, so we need to make sure that we do a correction for doing these 15 planned comparisons. Since we want an alpha level of 0.05, using only the feature sets that have p-values less than 0.0033 are determined to be significant with a Bonferroni correction. This table will show uncorrected p-values. As expected, all comparisons between the feature sets with and without the current distress state are significant. And as we visually observed, only the 4-class model has significant differences between the different rate estimation model features. Finally, we want to check how these 1-month forecasts would do if we extended them without new training 3, 6, and 12 months into the future. Specifically, we want to see how our models will do when we estimate whether there would be a distress event at sometime during the next M months. Here we compare the holdout test set MCC scores for each of the 2, 3, and 4-class models. We're going to plot using the best feature sets for each of those setups using the validation MCC score. This turned out to be the state space model with the current distress label in all 3 cases. Here we can see that the red 2-class model results perform well above this black baseline model at all 3 time points. We also see that the 3 and 4-class models perform above baseline and are lower than the 2-class models at the first 2 time steps, but overlap here at the last. And for those of you that prefer accuracy scores, here we can see that the 2-class model is above baseline, again here in red, above the baseline in black for all 3 time points. Interestingly, you might notice that the 3-class model increases as we go further out in time. This observation, in combination with the relatively low MCC score, leads us to believe that these models were predicting nearly the same label for each person, And after we took a quick check on the predictions, we confirmed that this was true. To recap, we found that the basic plus current distress plus state space models performed the best on all three setups of this forecast problem. We found that the feature sets performed above baseline in terms of both MCC and accuracy. We also confirmed our hypothesis that adding a current distress label significantly improved all feature categories. We only confirmed our hypothesis that the state space features would do better in only the 4-class models. And finally, we found that the 2-class model performed above baseline for the 3, 6, and 12-month forecasts without further training. And this wraps up our work on forecasting distress. And of course, summarizes our contributions. Of course, there's a lot left to do to continue to make progress in creating accurate forecasts of mental distress. For example, we should include a wider array of diagnosis and prescription data when identifying distress and claims data. The features we used were heavily influenced by expert opinion, but we could also let the data more directly identify distress without our external biases. Secondly, instead of having to build a second model at the end of the state space point process, we could directly incorporate different biological systems into this model. A similar model has been used for modeling second order and higher dynamic correlations in neural spike trains. And we could do something similar by, instead of having a single binary vector of healthcare events, we can split those apart into specific biological subsystems. For example, maybe one binary vector for cardiovascular visits, another one for GI visits, and another one for mental health visits, and so on. We could then directly see how more events in one category affect those of mental health or other biological systems. We could also start to incorporate the knowledge of what medications individuals are taking and other daily behaviors, such as how well they slept, as control variables in the state space model. We already know that there are many off-target effects of medications or how drugs interact with systems outside of their primary target. And by taking this information into account, we might be able to better understand and get an estimate of that latent resilience state. And finally, we could explore using other models like LSTMs or hidden Markov models that take explicit advantage of time series data in order to improve the distress forecasts. For our current forecast model that I showed you today, we're only using pairs of data. Instead, we could be using longer sequences of data to improve these forecasts. Of course, none of this work is possible without the support of many people. Grad school can be very lonely at times, especially during coronavirus. And I feel very blessed to have had my eyes open to the many more people that are with us than against us. So specifically, thanks to Roz for taking a chance on me 6 years ago and for being a great advisor over the years. Zach, thank you for reminding me to focus on the critical pieces of this work. And Denny, thanks for encouraging me to make progress towards understanding the progression from health to illness. Special thanks to Deneen and her team at UHG for helping me get access to the awesome data sets and for your mentoring throughout the process. I'd also like to acknowledge the awesome group that Roz has built over the years. A special thanks to Christy, Craig, Natasha, Asma, Akane, and all other group members for being awesome collaborators and some of my very best friends. The Friday walks, talking about mobile games, and late nights at the lab with you awesome people have kept me going over the years. And also thanks to Sable for doing all the invisible work behind the scenes to make us look good and keep moving forward. I've also had the great fortune of being a part of a great cohort of students and being supported by the MAS office. Special thanks to Monica, Linda, Lily, and Sarah for all your help over the years. There are many other groups of people who've helped me get to this point, and I thank each of you. I'd like to acknowledge also the support of my family members. There are far too many of you to name, but I appreciate the support each of you has offered over the years. To my parents, thanks for teaching me to be curious, to see the whole world out there, and to take the road less traveled by. It's made all the difference. And finally, I'd like to acknowledge my husband, Cameron. Thanks for your kindness, your never-ending optimism, and for being my best friend. And thanks for attending today. I'd be happy to take some questions.
All right, Sarah, I'm going to go to the chat and see if we have any questions there. It looks like just fans there right now. So people are typing all kinds of affective remarks to start with. Zach has a question. Zach is pointing to himself. Zach, let me unmute you. Whoops. I think you can be heard. Try it.
Testing?
Yeah, I can hear you.
Excellent. So nice work. You did focus. That's excellent. But here's the parameter space that you explored seemed to me mostly around the intervals and their spacing and their length. What you didn't do, what you sort of hardwired from pretty early on was the visit type. So you said they're all the same. You could imagine that certain visit types are more disclosing of anxiety or distress than others. And certainly looking at an inpatient visit, looking at a psychiatrist visit would tell most people that there's more distress here that meets the eye. The second thing is that you defined some criteria, what's going to be the stress across the three instruments, but you could have made it more stringent or less stringent. And so I didn't see you explore that space. So I'd like to hear you think out loud, how things might have gone or what you might expect to see if you had looked at the different visit types and why you didn't do that. And the second part is what you might expect to see if you relaxed or tightened up the criteria for distress.
Thanks. Those are both great questions. So yeah, it is a big assumption to assume that all visits are created equal, because we know that intuitively that's not true. If you're getting a massage, that's very different than going in for surgery. So I think that that looking through that and seeing if we can, if there are signals that are directly labeled on those interactions that we can use instead of trying to force some sort of knowledge we have into those. Your suggestion of inpatient versus outpatient visits or the provider type is a great place to start. So maybe instead of splitting by biological systems, we just split by how many times are you going into the hospital versus how many times are you going to see your primary care provider. In terms of looking at the different cutoff points for those standardized surveys, I did play around with, and I didn't include it here, but we did play around with some different levels for those various scores. Because those cutoffs they have high sensitivity and specificity, but at that point when you have scores that high, you really are drowning in mental distress. And so we really like to be catching people earlier. So I think that if we did make those cutoffs lower so that lower levels of distress would be labeled as such, that we would see a lot more switching. Right now, it tends to be that somebody is not distressed and then they are distressed for quite some time. If we had a lower threshold, we might see more jumps between the two states. I would also expect that that might help us get at somebody in a quicker fashion if we're capturing the lower distress state.
All right.
I think Deneen has a question.
Yeah, Deneen, are you unmuted or do I have to find you here? Whoops. There she is. Okay. You're unmuted, Deneen.
Super, thank you. So Sarah, nice job. Really nice job. This is sort of a two-part leading question, but why did you choose the diagnosis you did, depression, anxiety, pain, sleep, and as it relates to indicators of distress? And at the end of the day, is this really a model about women? Because I think of the labels that we put on people, and if you look at a lot of medical claims data, the top 10 are mental health for women, and for men it's cardiovascular drugs. And so I worry that we label women with these words you use, and men we say they're angry or and it comes out in other ways such as high blood pressure. I'd love your thoughts on that.
Yeah, I think this is a really important point because the biases that exist in the data, our models will learn from that unless we provide some pretty heavy-handed oversight. So I chose those 4 categories because they are the traditional mental distress type categories, but you're absolutely right. There's probably other ways that people are being labeled that aren't going to be brought to mind. I believe there's one called adjustment disorder that I didn't include, but I think that that would be one that I would include later. Still, I believe more for women, but your idea of using these other labels would be great. I think that also doing prospective, all of this stuff was retrospective. So if we were able to prospectively gather these standardized surveys on different individuals, then we could look at their claims data or what a clinician observes in connection with that.
Thank you.
Thanks. I'm going to the chat where there's a question from Judd to everyone that says, "Yay, Sara, how do you measure success rate of catching mental distress before it occurs? Is it a general decline in diagnoses and prescriptions?" And I'll unmute Judd too in case he wants to add to that.
Cool. Thanks, Courtney. This is a tricky one, right? Because it's hard to tell when you are successful at this, because there will probably be a lot of cases that we are interacting with people that perhaps don't feel like they are stuck in mental distress quite yet. So I think that this is also a self-reflective problem too, that maybe these self-reported surveys themselves, we don't know. But I think that we could use some like traditional medical claim stuff based on like utilization. So how much are these people visiting the doctor? It's been shown that things like depression multiplicatively increase the amount of times that you're going to the doctor. And I think that we could look at other aspects of somebody's mental well-being. They should be able to feel like they are fulfilled and thriving in their life in other areas.
Okay. From Kendall Clement, you showed results forecasting crisis likelihoods at several future time points. Have you also looked at predicting the time to crisis given a patient's current state?
Yeah, thanks, Kendall. I did. So the way that we actually computed the probability of having an event, we can actually compute the probability all the way through that time period. I don't have results to show you right now, but I think that that's something really interesting because you would want to prioritize, if you have limited resources, getting to the people who are going to be at risk, have issues earlier, have mental health things that we need to address earlier. So that can be computed, and I just don't have beautiful plots to show you today.
Kristen, I'm unmuting you. You can ask your question live if you want, or I can read it.
Sure. So building on Kendall's question, the whole idea of hitting a crisis point is often caused by a triggering incident. Do you think you could catch the likelihood of somebody being triggered based on their current state before one occurs so that the patient could prepare and lessen the effect of a trigger?
I would hope so. There are some things that we know. These are those conditions, right, of like a forest fire. If you know that the area is dry, you might station people to watch for forest fires so that when it does happen, you can have somebody on the ground right away. But I think there are also things we can do before to adjust someone's environment and possibly help them gain tools that they need to be able to better mentally prepare for things. I don't think that we're going to get rid of or prevent all mental distress. I think that that's a part of life, unfortunately, but I do think that we can be ready to react much quicker than we are right now.
And
thank you.
Of course.
So Denny has his hand raised. Denny, I think you're unmuted.
Yeah, can you hear me?
Yep.
Okay, Sara, well, first of all, congratulations. A terrific job, and it's been a real pleasure through our several meetings of working with you on this. I'll follow up with one of the questions you and I have discussed before, but I think will be important to your future work and that of others. and that is, of course, of the behavioral idiosyncrasies that are implicated in the overall results here, but of course are not readily studied given the current format. So by that I mean the obvious that, and a little bit associated with Zach's question, that not all signs, symptoms, or even presentations are created equal, or the null hypothesis, whether people even show up in the first place. And of course, those have not only medical consequences, but they could be the result of financial, social, cultural, other aspects. And one of the things we did discuss, and I'd still like to hear your opinion and would require future work, is that the potential way to get at this, and maybe the only way, is to have a more holistic approach with comorbidities as to the association and impact of distress versus resilience on other medical consequences, the more traditional ones in heart disease, lung disease, etc. So I just wonder how going forward you will be able to incorporate what I think will be absolutely necessary, which are the behavioral performances, if you like, and variabilities of each of your characteristics.
Yeah, that's a good question. So I think that you're absolutely right. One of the major limitations of this work is that not everyone goes to the doctor and not everyone has insurance. And I think that there are ways, so a lot of this work has been expanding on the different data sets that we do have. We don't have a bunch of standardized surveys for everyone, so we've worked on ways to expand those using different models. I think a similar thing might be able to be done with behavioral data. A lot more people have, sadly, have smartphones, so then perhaps are visiting the doctor. So we could be using the people that we do have clinical information on to get some more information about how that manifests itself in different behavioral interactions. I mean, things like how are you interacting on the internet? Are you interacting with a social group that has positive values? Do you move around during the day? Do you interact with people that make you happy? And those sorts of things I think we can start to get at using smartphone and wearable related information, things that are outside the traditional, what is now the traditional healthcare system. But I think you're also right in that it's not just one thing that we're talking about right now. If you're distressed, it impacts every aspect of your life. And we would expect to see not only differences in how you're perhaps physically responding in these like lab tests, but also ways that the ways you're thinking are going to change too, right? And that will change the way you behave in relation to people around you and in relation to people on the internet and through other means.
Thanks. Maybe on the private chat channel, Andy sent a question. I'll go to him, and then after Andy, we'll go to Matt Groh.
Yeah, hi, apologies for sending it on the private channel. No particular reason for that. Lovely job, Sarah. Congratulations.
Thank you.
I'm an engineer. I can't help but think of how we use this to fix things. Like, is there a way a person could use this information? This is very similar to Kristen's question, in the face of externalities like losing your job, to help guide treatment and your interaction with the medical system.
Mm-hmm. I think one of the ways this work could be used is if it is an early warning sign of who might be distressed, then we can, in our clinical studies, our controlled trials where we're trying to select people and run interventions to see what works and what doesn't, we can be much more targeted towards those people that we think have a high likelihood. Right now, we kind of just take the whole population and hope that some of them are the right people to be studying. So while I don't think that this one, I could give it to any individual person right now, looks more from the top-down system level, but it could offer ways for us to do the right interventions, to do those tests for the interventions that we can do from the more bottom-up way.
Okay, Matt Groh.
Sarah, awesome presentation. Really love the work. And one of the things I really like about it is how many applications to the real world there are, given that these are electronic health records and claims data that exist. And so the question that I'm curious about is, if you were to implement your research, let's say across all hospitals in the United States, what would you change? And one of the things that you did was you dealt with this as like kind of a binary or as like a 4-class kind of problem, but I'm kind of curious about severity of distress. And so would that matter that in, and how might you do that? And yeah.
Yeah, thanks. That's a good point, that we didn't take into account severity here. We're doing very discrete states. We could do more severity related things with those standardized surveys. They do give us scores from, for example, 0 to 27, so we could start to learn things like that. But I think that if we were to implement this sort of thing, I would imagine it being a heads up right now for the clinician. I don't think that work like this or any work in the AI clinical space should take over the task of a doctor, but they have so much to keep track of. I think it's our obligation as data scientists to help them see the best possible ways forward. So I think it would be great if we could use a tool like this to give them a way to connect and reach out to people who they know are at higher risk. For example, there are certain situations, for example, pregnant women. There are some individuals that are at much higher risk there that could probably use some more support. With the current coronavirus pandemic, if your doctor knew that you were at higher risk, this has just been a big catalyst event. So there are probably people that we could reach out to right now and say, here's some tips and tricks on doing some things to reduce your anxiety, and here's some people that you could talk to.
Okay, Denny has his hand raised. I'm unmuting you. Trying to unmute you. Huh, funny, it's not unmuting you. Denny, can you unmute yourself? There, now you are.
Yeah, that must just be a duplicate. I asked my question, so.
Okay, you can lower your hand. All right.
Okay, how do I do that?
I just did it for you. Okay.
All right, thank you.
Thank you. We'll learn all of these little crazy things. Okay, a question from Noah. Let me see if I can unmute you, Noah. There you go.
Oh, hi. Yeah, I pretty much described it in the chat. Basically, I saw that you had data on socioeconomic status and kind of income, and I was wondering how that might affect the the state-space models with allostatic load, given that proxy was kind of assumed some access to care. So I didn't know if you could maybe talk a little about that.
Yeah.
The question was about kind of similar to Matt's point about, in the ideal case with that, ideal set of data, what do you think it would take for maybe more personalized kind of models, personalized care? And understanding that, the knowledge of a doctor is definitely in the loop, but we're just curious if you could speak on that as well.
Yeah, some of these questions today are making me think that, as you're pointing out, that maybe we could use those SES factors to give us some sort of information about how people are able to access care. Because for those people, a large set of visiting the doctor in a row probably means something different to somebody who has a different kind of access. So one of the things that the state space model does is that it assumes that all of the history components are the same across the entire population. So it's possible that instead of forcing all these to be the same, we split them into different, sorry, I don't know if I can, okay.
Oh.
We're good.
I'm sorry, Sarah. I just switched to, I had a request to switch to gallery mode so everybody could see it. And right when you were trying to share something, so I pulled your screen share.
It's okay, no, you're good.
Yeah.
Okay, so as I was saying, we can split the population perhaps into stratify them by maybe proxies of access to care and use that history effect differently. We already have the resilience effects are already being used as individual factors. So that's already individualized. Yeah.
See. And the second question was more so about maybe how passive data, other forms of data, online data may improve a real resilience or a personalized model. Just any kind of thoughts about that?
Yeah, so I think that I'm really excited actually to look into how people are using various prescription drugs and how various information that we can get from wearable devices like your quality of sleep can influence this. We can directly use this in that state equation. So remember, it was just a random walk model with just the next state there is just a random step from the previous state. We can also add a control variable in there that forces it either better or worse depending on these different control variables. So you might imagine that for one group of individuals, having high quality sleep is going to be really important to their resilience. Whereas another group of individuals, it's actually that they're moving around or that they're engaging with various people. And that's how we would learn those parameters. That would require a lot more data, but we could do something like that in this framework.
Any other questions? People, I'm going to encourage people, if you can, before we wrap up and give Sarah a final round of applause, to put your video on for a moment, if you can, so Sarah can see you. And if anybody has any other questions, you can raise your hand. I think I can see you right now, or the chat. Apologies for this non-live thing, but everybody's being safe, and thank you all. It's kind of historic to group Zoom.
You all look great.
Defend.
Great job.
All right. Well, with no other questions, then what we'll do is we'll congratulate Sarah with a round of applause here. Then
Here.
break out for a private. Yes. All right. Great job, Sarah. Okay, so
Thank
can
you.
we break out to the different Zoom room that you guys were sent a link to? I can send it again if you need. And then Sarah, I will text you on Slack to join us there in a little while. Okay.
Okay, sounds good.
Break.
Could you just post, for simplicity, could you just post the Zoom link in the chat?
It's private, but let me find it and do that.
Oh, okay.
Yeah.
All right. Never mind. Okay.
Yeah.
Well, you think it's in an email?
Yeah, let me do it in an email. Okay. All right. Thank you. I'll send it to you guys again real quickly. Okay. Cheers.
Okay.